So Peppy Brock was born and brought up in United Kingdom. And in order to fulfill her dream to do medicine, she had to go and study medicine in Belgium. She then went on to do her PhD in cisplatin ototoxicity, which Peppy will explain to you is one of the most potent drugs in cancer treatment. And then she returned and she was headhunted for the post in Great Ormond Street Hospital. And she led cutting edge research in developing autoprotection. So she's also a consultant to pharma company called Fennec Pharma. But from another aspect is that she was the founding member of UK Medical Aid to Pakistan, which was started following the earthquake in Pakistan. So without any delay, I'd like to welcome Peppy and thank you very much on behalf of all of us for agreeing to chair this, or to agreeing to be our first speaker for the Trailblazers in medicine.
Okay, so I've been asked by Kaukab to talk to you about my journey from medical school to drug discovery. So medical school, why did I go to Belgium in 1974? Well, actually, when I finished my A-levels, I went on holiday to the south of France. I went on a Christian Movement for Peace camp, and I met my first husband there. And we traveled back to France together with a number of people and stayed in a wonderful room for the night with my cousin, who had a French-speaking mother who was working in Paris. And then we stayed friends. And while I was battling to get into medical school, I tried UCAS 3 successive years and failed to get into medicine because I had a particular interest in music. I played the oboe, I did music A-level, and I was torn between music and medicine. Anyway, in the end, my elder brother said to me, Peppy, why don't you just go abroad? So through the friend that I'd met, I applied to university in Belgium and was very surprised to not only get an offer, but I got the offer as a man. It was Mr. Brock that was invited to come to Leuven University, which of course made me despair because in those days, they only took 5 to 10% of women into medical school in England. And so I just assumed when I got over to Belgium and they saw that I wasn't a man, that I would lose my place. But my mum was a great professional. She was an architect and she was very, very determined. And she just said, right, we'll get in the car and we'll go over and we'll see what happens. And when I arrived there, they didn't seem bothered at all that I was a woman. But I wasn't allowed to get a room or any type of lodging until I'd taken an exam in French to show that I could speak enough French. Well, I was hopeless at French. So I joined a course with all the other students, and we were taught, rather like you teach English to foreign people, we were all in the same room, all learning French, but all coming from completely different countries. So I camped outside the town in Louvain and waited, walked in and out of town to go to the language laboratory, learned French, and managed to pass the first exam. And that allowed me to rent a room, which was good because by that time it was getting pretty cold. I went over there in July and I camped until October, and it was chilly. They'd closed the campsite, but they'd left the toilet open for me. And then at the weekend, other people would come and camp. Anyhow, I got my French exam. I got a room in an old convent where boys were not allowed in. So my boyfriend wasn't allowed upstairs. And I got into the conservatory in Leuven to play my oboe. That was what I really wanted because I loved playing, and I joined the university orchestra. And we then married in 1977, and I qualified in 1981. What I hadn't appreciated was it was bilingual in Leuven when I first went there, but they'd had a tremendous uprising in 1968, and the Dutch-speaking, the Flemish, had won the uprising, and they'd basically kicked out all the French speakers, and half of the university had to move to what then became known as Louvain-la-Neuve, or for Medicine Louvain-en-Woluwe. I qualified, much to everybody's surprise, including my own, in 1981. And out of the 1,000 students that started in the first year, we were only a couple of hundred that qualified. They were ruthless at eliminating you if you didn't get through your exams. I then decided that I wanted to study pediatrics. And that was partly because I'd wanted to be a GP, but in Belgium, being a GP was a bit different to being a GP in England. In England, you had your own sort of clients or patient group, whereas in Belgium, you can go and knock on the door of any doctor, and if you don't like what your GP says to you, you go and knock on the door of the next one and get exactly what you want. And I thought, I don't really want to work like that. So I thought I will study pediatrics because you could do general pediatrics rather like general medicine, and I liked that idea. So in 1986, I qualified as a pediatrician, or, you know, I got onto the pediatrics register. However, what I discovered in the 5 years I was studying pediatrics was that I was meant to go abroad to study for 1 year. But by that time, I'd had my first son, Thomas, in 1983. And going abroad was not very practical with him at that time. And so I created a sort of wheeze, if you like, that I would go abroad, but I would stay in the same town and just go to the Flemish speaking part of the university. So I went from the French speaking part to the Dutch speaking part, learnt Dutch. That was a bit of a struggle. And that counted as my year abroad. So I qualified with UCL, but actually by that time I was at KUL, which is the Katholieke Universiteit Leuven, which is the Dutch speaking one. And then I was particularly interested in oncology, and I joined the international group of oncology, which is SIOP, Société Internationale d'Oncologie Pédiatrique, in 1984, and presented my first paper in Barcelona in 1984. 1986, I'd met this wonderful man in the top corner here, John Pritchard, in Barcelona in 1984. And he was absolutely delightful, introduced me to loads and loads of people and said, Peppy, you need to come and be a fellow at Great Ormond Street. And I suppose what I'd started to learn by that time was that everything is through the people you know. My whole career is going, if you like, from person to person, building relationships and taking opportunities that come presented in this way or that way, and sort of just going for it. So the first time I arrived in London to start as a fellow in 1986, I went to John's office and he said, okay, so what subject are you going to do for your PhD? It never crossed my mind that I would do a PhD. And I had no idea what subject I was going to do. So he sort of said, you've got these options. And the cisplatin toxicity sounded quite interesting to me. So after a couple of days, I said, okay, John, I'll do cisplatin toxicity. And I did, and discovered that cisplatin, which people at the time laughed at me, they said, you know, people won't be using it in a couple of years' time and you'll have done all that work for nothing. What I discovered was we're still using it, and it's still a key drug all these years later. And I studied the toxicity on the bone marrow, toxicity on the kidney, and toxicity to the ears. And then John was so enthusiastic, he launched SIOP-HEL, which is the SIOP epithelial liver tumor group, and SIOP-PEN, which is the SIOP Europe neuroblastoma group. And he basically got me involved in both. And if it wasn't for John, I would have never been part of either SIOP-HEL or SIOP-PEN. So I have a huge amount to thank John for. Now, John was passionate about both liver cancer and neuroblastoma. And back in the days in the 1980s, most children died of cancer. And what we were striving for was to try and improve the cure rate. Hepatoblastoma, which is the most common type of primary liver cancer in children, is very rare, and all pediatric cancers are rare. But what we noted about this particular tumor is it produced a marker, the AFP, alpha-fetoprotein marker, in the blood that you could measure. So it was an extremely useful tumor. So we discovered with a colleague from Belgium, who had actually taken me to SIOP in 1984, great buddy of John Pritchard's, that both cisplatin and doxorubicin worked to shrink liver tumors in children. The adult oncologists were horrified when we started using chemotherapy in children. They thought it was barbaric, which, to be fair, it's pretty horrid. But on the other hand, if you can cure children, then we felt that we should at least try. And this, when I went back to Belgium in 1988, this was my first patient with hepatoblastoma who presented in 1988, and I had gone back, not yet as a consultant, but as sort of senior registrar. And the head of pediatrics came storming down to the pediatric ward and said, "What do you think you're doing? You can't give chemotherapy to this child with liver cancer because he needs surgery to cure him." And we had a huge row. And I can remember saying to him that the last child, before I'd gone to London, had died on the table of his liver surgery. And this is because, if you can imagine, a liver tumor is huge and it's got a massive amount of blood flowing in and out of it, very close to the heart. So the poor anesthetist, when they anesthetize a child with a huge liver tumor, when the surgeon comes in and clamps those big blood vessels, it rapidly, massively changes the flow of blood to the heart. And I saw the previous child die with an attempt at taking out this tumor. And I argued that he should give me one chance to treat this child with chemotherapy. Anyway, fortunately for me, the tumor shrank down absolutely beautifully. I don't know whether you can see it here, but this is the size of the tumor. I mean, it's enormous compared to the tummy of that child. Shrank down to this size, much, much safer to operate. And the surgeon was able to take the tumor out. And this is now a lovely young man in his 20s. So that was the excitement of starting chemotherapy in Belgium. So what we were doing with John Pritchard and what he was trying to do was he formed this society. It was actually formed at a SIOP annual meeting in Jerusalem in 1987. And we were trying to improve the cure rate of children with hepatoblastoma, introducing cisplatin and doxorubicin right across the world. 40 countries joined us in this determined effort to improve the cure rate of liver cancer. And then the surgeon at the time, who was Jack Plashkes, we started using MRI scans, and Jack Plashkes designed, if you like, on the back of an envelope, a pre-treatment extent of disease, because the MRI suddenly gave us such beautiful imaging of the liver that you could see which surgical sectors were involved by the tumor. And for a surgeon, so once we'd given the chemotherapy, the surgeon had to take the tumor out. The surgeon was really interested in how he was going to operate the tumor right from the beginning. And surgeons can either take out half the liver, or they can take out a quarter of a liver, or they can take out 3/4 of the liver. But basically, it's determined by the blood vessels, blood flow to that part of the liver as to how they can operate. So they were interested in knowing how many of these surgical sectors were involved from the beginning. And what happened with the SAPEL group is, over a 30-year period, we increased the cure rate from 30% of children that survived with surgery alone, those were only the children with a small tumor at diagnosis that could be completely removed, up to over 75% with additional dose-intensive chemotherapy. And that's for high-risk disease. We actually cure over 95% of children with standard risk disease. Standard risk disease is pretext 1, 2, or 3, and high-risk disease is pretext 4, where the whole of the liver is involved and the child needs a liver transplant to be cured, or the lungs are involved and there are lung metastases. So if you like, these are what I call the SAPEL suite of clinical trials, which I've been involved in right from the beginning. SAPEL 1 started in 1990. All the children were given platinum and doxorubicin, coined as Play-Doh by John Pritchard. We were driving back to Zaventem Airport in Belgium. He'd been over to visit me, and we passed a Play-Doh children's store And he said, Peppy, that's what we're going to call cisplatin and doxorubicin. And then we got on to SAPL2 because the toxicity of doxorubicin is horrible. Doxorubicin causes cardiac toxicity, and the children later on can need heart transplants and have problems with their heart for all of their lives. And so SAPL2 was a pilot that we launched from Amsterdam. That's where we did the thinking, where we were going to try cisplatin alone. And cisplatin alone worked. So then in 1998, we launched SAPL3 for standard risk hepatoblastoma, where we did a randomized study between cisplatin and Play-Doh to see which one was best. And it was aimed at being a toxicity reduction study, get rid of doxorubicin and see if cisplatin alone was good enough. And I will show you the outcome of that in just a moment, but I'm just going to show you that SAPL6, after we've done a couple of other studies, looked at cisplatin, which was successful as monotherapy, versus cisplatin and the otoprotectants, that was the drug that we discovered to try and prevent the children going deaf from cisplatin. Now, while all of this was going on at Great Ormond Street, the audiology predecessor to Kaukab, Sue Bellman, was absolutely horrified at what was happening to these children's ears while we were giving them cisplatin. And what we were seeing was, with very high doses of cisplatin, this awful fall off. I don't know how familiar you are with an audiogram, but Kaukab, of course, can explain these much better than me. But basically, you've got the level in decibels. That's how loud the sound is, going from no sound at 0 decibels through to a high sound. Oh, sorry, don't know how that happened. High sound of 120 decibels. And what you're seeing along here, just be careful not to trigger it going again, is the frequency of the sound. So lower frequency sounds here and high frequency sounds here. And what you see is the normal audiogram to start with. So the child is showing that they can hear all these frequencies at very low levels of decibels. And then sadly, at each cycle of treatment, the curve is falling off at about a 45-degree angle, showing that they actually can't hear the sounds that are in this corner up here. And then after the second cycle, they can't hear these sounds. And so we published the fact that high dose cisplatin was a real problem for hearing. Now, this should have become the Sue Bellman classification or the Great Ormond Street classification, because Sue very generously let me be the first author on that paper. It became known as the Brock classification. And she made a very nice cutoff at 40 decibels, where we could clearly see that a child had either minimal hearing loss, mild, moderate, marked, or severe, depending on the level of that line, if you like, of the audiogram that came from the test. So if you look at what we call the speech banana, these are the phonemes that are sort of put onto an audiogram to give you a feel of when you can hear them. So right up these high frequencies up here, the they are high frequency sounds. Whereas when you come down here, the ooh, ah, or, they are low frequency sounds. And what the children are losing when they're getting a Brock grade hearing loss is that child with Brock grade 1 loses the th. They then lose the f. Now, S in English is an incredibly important consonant. When they lose S, they lose plurals, they lose all sorts of important aspects of speech. They then lose the d, t, and then we go on to Brock grade 4, where they start losing vowels. So if they've got Brock grade 4 hearing loss, the cat sat on the mat becomes a, o, a. And that makes speech very difficult for young children. Average age of getting a hepatoblastoma is 13 months. They haven't really developed language skills. They leave hospital, they go to nursery, and they're stuck, and nobody's understanding why they can't get the story and answer questions like the other children can. So we published the SAPL3 study, that cisplatin monotherapy with surgery is not inferior to cisplatin and doxorubicin in 2009. There's always a big delay between getting a clinical study up and running the study, and then processing the study and getting it to publication. But what this study left us with was a permanent Brock grade hearing loss in over 60% of the children. And so the next aspect that we as a group had to tackle was, how could we get rid of the hearing problem? I'm going to admit another person. Get rid of this hearing problem in the children who were doing so well in terms of cure rate. So the 3-year overall survival, that's what OS means, is 95% for children treated with cisplatin alone and surgery. So we've gone from 30% cure rate to over 95% cure rate, but children are developing hearing loss, which is permanent, it's bilateral, it's for life. So they're living a normal lifespan, but they're struggling with their hearing. So meanwhile, in Portland, Oregon, a fascinating man called Ed Newalt was looking at a product, sodium thiosulfate, and discovering that this could prevent people losing their hearing when they were treated with a sister drug to cisplatin, carboplatin. But this was carboplatin being given by blood-brain barrier disruption. Now, the reason they were using blood-brain barrier disruption was because the blood-brain barrier very carefully protects the brain from carboplatin and from cisplatin. But if you've got a brain tumor, you want the drug to get across that blood-brain barrier and get into the tumor. So he was treating with an osmotic process of injecting a product. The blood-brain barrier would open for a short period of time, give the carboplatin. Carboplatin would go across the blood-brain barrier, treat the brain tumor, and then the barrier would close after about 20 minutes. Then they were able to give the STS. And if you understand these bars, you can see that you've got hearing loss. So the other way around to the audiogram, 0 decibels here, hearing loss here. The red graph, if you like, are historical patients who have no STS, and they are getting hearing loss up to over 40 decibels hearing loss here at their 7th cycle. Whereas if you give STS, what they discovered interestingly was it has to be given delayed compared to the carboplatin. You get protection 2 hours afterwards. These are the blue blocks, and 4 hours afterwards, the yellow blocks. So he pioneered the preclinical studies initially on rats, and I went over to see his laboratories, and these little rats with little hearing apparatuses on being tested. And he managed to show then, after the rats, when it was successful in them, in patients, that it protected their hearing. Now, the challenge was that I met Ed Newalt, and Ed Newalt and I wanted to try and use STS in children with liver cancer, but there is no liver barrier that we could block to get the drug into the liver and then get the STS into the liver. If you give the STS at the same time as the cisplatin doesn't work, so you don't cure the child. So Ed Newalt contacted a friend in El Paso, Texas, and asked if he could do a test on a rat model to see what timeline we could give the STS after the cisplatin that would be safe. And we only needed a body tumor, if you like, not a brain tumor, to do this test. And his friend, Pat Reynolds, had a human neuroblastoma mouse model. So this is the graph of the results of a mouse model study, where, if you like, very simply, this is the tumor volume, so you can measure the growth of the tumor over time. And we're talking about mice, so we're talking about something growing in days, not months and years. The black line is the control line. So basically, you have a mouse who has a human neuroblastoma, and it will grow at this rate over this number of days to reach at maximum at about 20 days, large voluminous tumor. You give cisplatin, the blue line, and STS at the same time, so at hour 0, and the tumor grows happily as if you'd given no cisplatin. Clearly, that won't work for us. But the green line is cisplatin alone. Pretty powerful effect on the first 20 days on the growth of the tumor. It almost stays stationary. What is fascinating is if you give cisplatin and STS 6 hours after your cisplatin, you get the same impact of the cisplatin on the tumor as if you'd not given any STS. So we know that if you give STS in a delayed fashion, actually up to 8 hours, you get protection of hearing. If you give STS 6 hours after cisplatin, you don't protect the tumor. So with this information, Ed invited me to the States. I invited him back to Bern, to a SAPEL meeting, and together we combined forces and collaborated to set up the SAPEL 6 study. And the SAPEL 6 study was launched at Great Ormond Street, Christmas 2007. It was an international study. It was multi-center. It was open label, randomized phase 3 trial, where we gave half the children STS and half the children no STS. And Kaukab, thank goodness, very kindly offered to centrally review all of the audiograms of this study, which was very brave of her. She wasn't paid a penny for all of this. So this is SAPEL 6. This is the sort of diagram. The children get a diagnostic biopsy, tumor and blood storage, and they get imaging. And then they are randomized to either get the cisplatin alone arm up here, or to get cisplatin and STS. And they get 4 cycles of chemotherapy. The tumor then hopefully shrinks like that previous CT scan that I showed you. They get surgery to take the tumor out, and then they get 2 more cycles of cisplatin. So a very simple design. If you're going to run a study in many countries, you have to have a simple design that everybody can understand. And fortunately for us, a number of countries joined us. Sadly for us, we didn't get 40 countries joining us. Why? Because by that time, it had got much more complicated to launch a trial. You had to have a sponsor, you had to have a lot of money, you had to have a lot of agreements in place, and for a very rare tumor, it was becoming more and more difficult to get that. But we managed to get 12 countries to join us, and we used the primary endpoint as either Brock grade 1, more than 1, or less than 1. And we had to decide that we would measure the hearing of all these children once they'd grown to 3.5 years old. That's because we needed to have a really good audiogram that Kaukab could then review. And it's only really possible once they've got to an age where they can understand when they're hearing it to sort of press the button or show somebody with a toy that they've really heard it. But that was the design of the trial. And you can see here that these are the results. When we gave cisplatin alone, there was 66% of hearing loss, which was expected, as we thought from the SAPEL 3 study. And it was reduced to 38% when we gave STS. And that, for a new drug, is actually a very, very good result. Of course, we would love it to be 100%, but you know, you don't get that, sadly, in medicine. New drugs are often considered completely acceptable when you get small percentage changes. So to get roughly a 50% change was actually excellent. The most important thing was that we did not impact on survival. In fact, the 3-year overall survival of children with cisplatin alone was 92.3%. Cisplatin and STS, it was actually 98.2%. That sounds good, but statistically, there's no difference between the two. But the important thing is, by giving the STS 6 hours after the cisplatin, we had not caused any harm to the children. Now, in the meantime, people are developing a better idea of how to monitor hearing loss in children with cancer. And this is the K. Chang classification. K. Chang came over to Great Ormond Street and he was interested in the Brock classification, but he wanted to make it a little bit more specific, a little bit more sensitive. And so he took the more sensitive cutoff of 20 decibels to decide on a grade 0, which was normal hearing, whereas with a Brock grade at 40 decibels, you could have children with minimal hearing loss in there. And this was more specific. And he published that in 2010. In Boston, Massachusetts, they were having a meeting, and we decided, Ed and I will have a PSYOP ototoxicity symposium, and we will get to a consensus PSYOP scale where everybody's happy, it's not too complicated, and we can encourage people to use this scale in clinical trials moving forward so that we can compare how toxic, how bad the hearing is after treatment for one disease versus treatment for another disease. So this became known as the PSYOP Boston classification. It's then important to really study and look at what is the impact of high frequency hearing loss on children and on society. I've already mentioned acquisition of language. It has a huge impact on education, on social integration and acceptance, relationships and work, mental health, and now it is hearing loss has been discovered as a risk factor for dementia. Just looking at the frequencies used in different languages, I found it was fascinating to realize that children who are losing these high frequencies are much more impacted if they speak English or Russian. Sadly, I haven't got all languages here. And so it's important, particularly in England and in America and in countries where English is spoken, whereas I was puzzled by my French-speaking colleagues and my French-speaking friends, both in Belgium and in France, they weren't so bothered about high-frequency hearing loss as we were in England. And I think half the time they thought that me and Kaukab were making a bit of a fuss. But what we then realized is it's because our children speak English. And if you speak French, tout est beaucoup plus bas. Et alors, ils comprennent tout. They understand everything, even if they have high frequency loss. And then we started to see different North American collaborative quality of life studies coming out, really, really important, showing us how serious this hearing loss was. This is a very nice study published in 2015 from St. Jude's Research Hospital, where among the survivors of children with no brain tumors, so they're not having brain irradiation, which is another problem for hearing, but 39% were not living independently, 45% had never married, 34% had not graduated high school or were unemployed. So survivors with a serious hearing loss were at increased risk of all of these things compared to survivors which didn't have a hearing loss. This publication, which came out in 2020, very interesting study of neurocognition in survivors of children with cancer. If you look at these groups, survivors with severe hearing impairment, and they're using the Chang grading, you can see that right out here, for example, visual reasoning, academic function and word reading, all these things are highly impacted, working memory. So you can study this in great detail. It requires, of course, a lot of funding to be able to do that. And this was a beautiful study that was published only in 2021 about what is the prevalence of hearing loss, real prevalence in children who are treated for tumors, and looking at the type of hearing loss that they had. So I don't want you to read the whole of this. If you're interested in it, you can. But what's important is, for example, hepatoblastoma here, 65.9%. So across America, they're finding the same problem, that they're having severe hearing loss. Meanwhile, at Great Ormond Street, Kaukab is working very hard with a psychologist, Lindsay Edwards, to design not only Lindsay designed a quality of life scale for children with hearing loss, but Kaukab then put this test to children who'd been treated for various types of cancer. And what's important over here is that you can see that children who develop a hearing loss post-treatment for cancer have a statistically significantly poorer communication and independence, emotional well-being, peer comparisons, and peer acceptance. So a very important publication that also came out in 2021. Now, meanwhile, in Utrecht in Holland, I'm making contact with a wonderful young person, Annelot Meyer, who started a PhD, and actually, again, it's all communication and people. What happened was, I'd never met Annelot, but Annelot was in a center where a number of the consultants had been registrars with me in Great Ormond Street. And they rang me up one afternoon. I remember I was sitting in the front garden having a cup of tea, and they said, we've got this wonderful young person, Annelot, and she wants to do a cancer treatment related hearing impairment PhD. Will you help us? And I said, don't be silly. You don't want me helping you with that anymore. You know, what useful thing can I do? But they persuaded me to at least stay involved and be interested. And what is fascinating is it has led to a wonderful collaboration. And it led to a PSYOP supportive care publication, which many of us, including Kaukab, were involved in, where we were able to publish how children need to be tested, when children need to be tested, the long-term follow-up of children at school and in the community, how to grade audiograms, and the importance of central review of these audiograms. And then meanwhile, I was invited to become the chair of the public advisory group for Chiltern. Chiltern stands for the Children's Liver Tumor European Research Network project that received funding from Europe. And this became the advisory group activity, where we called it Live Again. Once the group met, they didn't like the terminology of Chiltern Public Advisory Group, found it awfully complicated, and thought it'd be better if we called it Live Again, and I completely agreed with them. In this group, we have Phylly Simpkin, who's the mother of a child that I treated, Ollie, with hepatoblastoma, back before SARPEL 6 started in 1986. Jawad Tanvir, a wonderful dad of Maham, who is now an 18-year-old, wants to study medicine, but she had a very severe liver cancer for which she required 2 liver transplants. Extremely brave young woman. And it was her friends that made this beautiful sign and decided to call it Live Again. So we've got some stories here on the website, Ollie's experience, Christina's story, and Olaf's journey, and a number of projects that we did together with the public. And this is a Facebook group that Jawad set up with his daughter so that people could talk to each other. And then we decided what we really need is some videos where the experiences of Ollie when he was at nursery school, and Ollie's mum when they were at primary school, Maham and Ollie when they were at secondary school, all the problems that they struggled with and how they tried to overcome them. And we had a wonderful time with an animator to make these videos, and you can look at them if you want to. They're on the website and they can be accessed through the QR codes, which you can get onto your phone if you look at the slides later. So treatment and supported care of children if they've acquired the hearing loss is of course extremely important, as well as trying to prevent it. And Kaukab knows better than I that they need an individual treatment plan. There are all sorts of things that can be done to help them. We wanted to help educate them in the community. So together with Kaukab and others, we wrote an open book chapter and we prepared those videos. And we tried to tell them, well, I know Kaukab tells them, do be careful about extra noise-induced deterioration of hearing, because once they've got hearing loss, it can get worse, unfortunately, more easily than another young person. So how can we prevent and reduce ototoxicity in children who are going to be receiving cisplatin? Well, we can optimize their supportive care, we can adapt the platinum therapy, we can adapt the radiotherapy, but we can try to find drugs that help. Now, Kaukab, I'm aware of the time, so I'm going to race through these next slides. People can find them if they want them on the website, but I'm just going to give a feel as to what we did to find this drug. So the path to the drug discovery, we're looking for clinical candidates that are going to prevent the chemotherapy destroying the outer hair cells of the cochlea. The outer hair cells of the cochlea sit in the organ of Corti right in the inner ear. And this is the cisplatin interaction in a sort of image of that outer hair cell where there's a cascade and the antioxidant defense system is overwhelmed and the cell dies. And this is the general mechanistic pathway of the complex cascade, if you like, of events that happens to get a cell to this dreadful stage. Oops, sorry. Here, this red apoptosis. Apoptosis basically means cell death. So you get this cascade, cisplatin comes in and boom, 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 you end up with the cell dying. So you presume this is the outer hair cell of the cochlea. And what you want to do is with STS or with NAC or with DMET or with one of these drugs, try and prevent the cell from dying. And in 2018, this study was published of all the clinical candidates. At that time, there was one study published by David Fryer in the States with STS, and our study hadn't yet been reported. So our study then was reported in the New England Journal of Medicine in June 2018, where we showed that STS worked. And we then went on, David Fryer and I and a group of people, to look at how can we use STS in a clinical practice guideline. And then Fennec Pharmaceuticals, and I've been a consultant with them, are trying very hard to get this drug licensed, and we very much hope it will be licensed by the end of this year. And they very sweetly called this drug PEDMARK. This is the trade name, after me and Ed and David and Margaret and Anne and Rudolph and Kaukab. So the K in PEDMARK is thanks to Kaukab. So thank you, everybody. All these wonderful people throughout my career who have helped me, encouraged me, inspired me. So thank you. I have got other slides that you will find online about well-being, because I'm very, very aware that medicine at the moment is extremely difficult. I went on to become a counsellor after I retired. I counsel frontline staff, and I have just put a few pointers and a few what I hope are helpful slides for any of you who are finding life a bit tough.
So I will just quickly ask you a few questions. So what about side effects of the drugs? I think by this Shakiba Rangoonwala has asked this question.
Yeah.
I'm sure she meant the side effect of sodium thiosulfate.
Yes, yes, very, very good question. So sodium thiosulfate has a very, very high sodium load, extremely toxic. So if you like, it's a little bit like giving salt poisoning to somebody, which of course is horrible. So it makes them vomit. Cisplatin, unfortunately, makes children vomit as well. So you have to give it with a lot of fluid to flush it through the kidney, and you have to give it with antiemetics. But we're very fortunate. There are very few other side effects, and we've just put in a SIOP abstract with the named patient program, where there was only one serious adverse event of a child who got metabolic acidosis, which was easy to regulate. But otherwise, it's nausea and vomiting.
Okay, thank you.
Thanks. There's a question from Zara Shah. Zara, would you, so it says, can hearing loss in children be corrected using advanced surgical procedures, or can children be provided with specialized hearing aids to cope with adverse effect of hearing loss in their life?
So
I
I'm
think
going
that's
to
a
bounce
question
that
for me.
straight back to Kaukab. There you go.
I just realized that this was a question for me.
Great.
Zara, yes, there are aids available and there is surgical intervention. But you see, the point I always try to make is that what God gives us is the best. Man can never match what God gives us. So the hearing aids could work, but they're not the same. But the cochlear implant, which is the department I run, and it's one of the largest departments in the country, the children who have had normal hearing before they lost their hearing and had to have a cochlear implant, initially they find it really difficult. And they come and tell me, my mother doesn't sound the way I remember her sounding. It sounds a bit robotic. It sounds a bit like listening to Teletubbies or like cartoony, because it's quite robotic. So I think from my point of view, children, it's the last resort. But if we can preserve the hearing, that is much better. And I think we have discovered a drug which can minimize the hearing loss. And perhaps at this day and age, it should be the first choice, really. So that's my answer. Peppy, the question is, can you explain the delay in administration of the medicine? Would it make it more effective after carboplatin? So I'm asking, just let me be clear. You're wondering why the sodium thiosulfate is given after delayed.
Yeah.
So Peppy,
it's an excellent question, Zora. We don't actually understand why. It's extremely convenient because it wouldn't be safe to give it at the same time. But actually, we don't understand enough about the exact mechanism as to why it works better when it's delayed. So it's very convenient. Hopefully, at some point, we will understand better why that is.
So Peppy, how I understood was that the half-life means how long the drug remains in the blood of cisplatin, but it's not been very well researched.
It's the half, yeah, in terms of protecting the cisplatin from the tumor, yes, that's exactly what it is. But I think Zora's question is, why is it that giving STS delayed protects the hearing better? And that's the question that we haven't yet answered.
So I think there is a theory, and because ear is my area, the theory is that the blood supply to the ear is not as great as the blood supply to the brain, maybe, or to the heart. And the clearance from the ear is not good either. Again, not as great as some other parts of our body, for example, the cleaning of the blood or removing the toxins from the blood. And so once cisplatin gets into the inner ear, it doesn't leave it. It stays in there. And then it can continue to be, to harm the cells, and the cells will die eventually, because the toxin is still there, although it's got a short half-life, but then it clears the blood quicker, but it then sits in some areas and it produces, free radical, which kills the cells. So it stops so I think we still have not got any scientific evidence of its mode of action against inner ear cells. That is something it's probably another lifetime of work for someone, not me.
Thank you.
But thank you very, very much. And I'm sure the audience enjoyed. And if they have any questions, they can always email Zora, and we can ask you those questions.
Yes, so our email account is info@bpfuk.org. And we're looking forward to hopefully the next session of the Trailblazers in Medicine that we're expecting in June. So we hope to keep everybody excited, and we'll keep you up to date on social media.
Thank you. Thank you.
Thank you. Thank you, everybody.
Thanks.
Bye
Thanks.
bye, everyone.
Bye.
Thank you so much.